The next group of pathologies that we're going to talk about are infections of the skin. Um, Infections of the skin can be caused by uh, bacteria. So that would be things like boils and impetigo, cellulitis, which is going to be this video. There will be viral infections, so that's warts, plantar warts, herpes simplex 1 and 2, and herpes zoster, which we've already talked about. Then the fungal infections, ringworm, uh, Tinea capitis, Tinea uh, pedis, uh, those sorts of things. Candidiasis would be a yeast infection. Um, then there are infections of insects, scabies and lice fall into that category. So for this video, we'll be talking about the bacterial infections. The first bacterial infection that we're going to talk about is boils, um, furuncles. It's caused by staphylococcal infection, and it's a very localized thing. It's kind of like pimples are small boils. Um, it's usually caused by Staph aureus or Staph A, and what happens is that the bacteria gets down into the sebaceous glands, um, into the base of the shaft of hairs, or sometimes at a site of an injury, but usually it's in hair shafts. Um, uh, so there's Staphylococcus is an interesting bacteria in that it mutates very quickly, and Staph aureus is a particularly virulent variety of it. And now, well, actually, probably for the last 50 years, there have been um, there have been Staph aureus subspecies that are resistant to various antibiotics, and it seems to be more and more. The big one is called MRSA, which is um, methicillin resistant Staphylococcus aureus, and they're resistant to penicillin and methicillin and all kinds of other um, things. Now, it often happens, the boils happen because of it, where there's a lot of sebaceous glands and where there's a lot of hair follicles in the same area, and usually where there's friction or sweating happening at the same place. So it's really very common in the armpits and in the groin, uh, or in the buttocks, right, kind of in between the cheeks. If it's found there, it's called a pylon. I always pronounce it pylononil, but it's pylonidal cyst, uh, and they can be very large and very painful. Um, so, as opposed to a pimple, a boil, it becomes large and obvious and painful. Uh, Usually, we get them one at a time. But sometimes they'll cluster together and they'll break out in a bunch of different places, and they're joined together under the skin by little channels that where the bacteria in, invest, and if that happens, we call it a carbuncle. Um, if it happens over a large area, like in the scalp, or uh, it's called folliculitis, which is in the hair follicles. So what what starts out as a small little raised bump, uh, it's hard, it's red, and the staph infection is there, will then get a center of pus. Now, uh, as this thing grows and gets bigger, it may rupture, in which case it maybe will open up to other infections, or um, if it's gone fairly deep, it might penetrate down into the dermis of the skin and leave scarring, leave permanent scars. Most of them just burst and then resolve. Um, Now you got to be very careful with them in that you don't want to pop them. You don't want to compress them and try and burst them, because what you'll end up doing is you'll drive the staph deep into the deeper tissues before it'll break through the surface. So, um, yeah, it can be a dangerous thing. There's a typical little boil on hairy skin. It happens at that hair follicle. This is folliculitis. It's like this series of boils in the hair follicles, obviously on the back of the neck. Uh, and again, you see them joined together here. So, because this is an infection, it's a staphylococcal infection, antibiotics work, but antibiotic ointments work. Sometimes hot compresses are used. Eases the pain a little bit, maybe causes more lymphatic drainage. Um, so, because this area of the skin really is avascular, oral antibiotics are not all that effective on it. But sometimes they're used, especially in the MRSA versions, like the ones that are resistant to the antibiotic creams and ointments, might need a different type of antibiotic and um, to use. Now, one thing that is dangerous about them is that they can harbor this staphylococcal infection, and then if it does spread into the deeper tissues, into the lymphatics, it can also end up in the bloodstream and cause a systemic infection, and that may be quite serious. Now, Staphylococcus is a fairly normal bacteria to have in your nose and places like that. A lot of times it can happen that if there's a small injury, a small nick, or some abrasion on the skin, and you kind of wipe your nose and then rub the sore, you can actually introduce staph into that little abrasion. Um, you want to keep them. You want to keep things clean. It's really important for healthcare workers about this, to observe these hygienic practices. You don't want to be picking it up on your fingers from one client and moving it to the next. It's one of the reasons that we're so adamant about hand washing and such. Sharing personal items like razors and towels can be a problem. You towel off vigorously and rupture a small boil, you can actually infect the towel. It's a problem with the linens with clients as well, because they can infect the sheets, your linens. So you don't want to be massaging over the boil itself, if you see it, or the carbuncle if there's a group of boils. Um, and you definitely don't want to enhance drainage and circulation and do that kind of work if there's signs of a systemic infection, if it's gotten too far. Cellulitis is on page 205 in your textbook. It's defined as a rapidly spreading acute inflammation with infection of the skin and subcutaneous tissue that spreads widely through the tissue spaces. It's usually caused by a streptococcus, strep pyogenes. Sometimes it can be caused by staphylococcus or even Haemophilus influenza, uh, but it's usually strep or staph. Now, the streptococcus that's involved is also the one that causes strep throat. It also causes impetigo, which we're going to talk about next. Toxic shock syndrome. Necrotizing fasciitis is the flesh-eating disease that you've probably heard about. So the difference between this and boils, if it was staphylococcus, is that this is not local. Cellulitis spreads rapidly through the the tissues below the skin, through kind of the open spaces in there. Now, for it to happen, uh, what has to happen is it's got to get in someplace. So usually it's some break in the skin, an injury. Could be people that are using intravenous drugs, that kind of thing is a fairly common thing. Like junkies get it along their track marks. Um, but it, the infection isn't necessarily at that portal of entry. What happens is that portal of entry is its doorway into this subcutaneous tissue that is very loose and very areolar. So there's lots of quick spread, probably lymphatically uh, as as well. Um, what it may or may not have an obvious skin infection beforehand. Things like a boil or something can actually turn into cellulitis. But what you get is red, swollen, inflamed, tender areas, and but there's no locus to it. There's no head. There's no pus. Now, what they start to look for is if you get inflammation along the lymphatics, along the in the lymph capillaries, and then along the collecting vessels, lymphatics, then the walls of those vessels get inflamed and turn red, and it will look like little red lines radiating from the red painful spot, and that means that it is now in the lymphatics. Um, and they'll move up towards the lymph nodes. Um, there's a subtype that affects the surface of the upper part of the dermis, the part just below the epidermis, and what they end up with is it's not as widespread. It stays fairly local, but these patches of skin are red and very painful, sharply defined borders. Um, if it goes systemic, you'll get all the systemic symptoms like fevers and chills and feeling like crap. If it actually starts to get into the bloodstream, it can turn into blood poisoning, into septicemia. And so it looks like this. Uh, you probably have seen it on some people. Uh, it can be um, it can happen post injury. Like sometimes it'll happen after there's been like a sliver in the fingers and that kind of thing. It tends normally to happen in the extremities, but it can happen on the face. Now this guy has got it on the face. Who knows where the original locus is? Now you'll notice that there is a blue line surrounding this demarcation, and this is uh, the surface one. And I can't pronounce it. Uh, but what that blue line is actually the doctor has used a pen and outlined the demarcation of the infection, and they use that mark to tell whether the infection is spreading, getting worse, or whether it's receding and responding to treatment. Uh, so, because of the risk of blood poisoning and the risk of it going systemic, and and how quickly it spreads just through the interstitial fluid along the skin, it is an aggressive thing, and so it needs an aggressive form of treatment. Usually, it's antibiotics because it is a bacteria, uh, and it could be oral antibiotics if it's a fairly well contained thing, but if it's starting to go systemic, they'll probably give intravenous antibiotics, really aggressive treatment. Um, so it really is a contraindication to massage. Maybe the local one with the finger you'd be okay, but as soon as it starts to look systemic, it is a contraindication. Impetigo is a very superficial skin infection. It's in the epidermis itself, and it is Staphylococcus or Streptococcus. Again, these are the big things. Um, you probably have all seen it. Maybe some of you have had it. It happens in a lot of kids, and it's usually on the face and around the nose. Um, but adults can get it as well. Now, what happens with this is that the skin gets itchy, uh, and 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 scratching can kind of auto-inoculate it. So the most common form, and the one that really that you see, is this impetigo contagiosa. It's a very contagious superficial infection with Streptococcus pyogenes. What happens is they get these small red spots, little red sores, and then they become small blisters very quickly, and then the blister starts to fill up with pus, and then this vesicle, this blister bursts, and the pus comes out, and the sore crusts over with this yellow brown pussy crust. It causes pain, it causes redness around the area, inflammation. It can actually lead to cellulitis if you do a lot of scratching and you work it deeper into the tissue. Um, Strep and staph are often found in the nose, and a lot of times you get the impetigo right there. Um, it A kid that's had a cold and has been blowing his nose a lot and has chapped areas, or from playing outside, or anything that causes that chap kind of break of the skin, uh, can lead to this. Uh, and like I say, very contagious. You don't want to touch it. Problem is with little kids, it's itchy. They touch it, they scratch other areas, etc. Another common place for it to happen is at crusted over mosquito bites that have been scratched too much, especially again in kids. They'll take the top off a mosquito bite by scratching, and if they've been touching their nose or something, they can actually inoculate the staph or the strep into the mosquito bite, and it can turn into an impetigo. Um, a more rare form, or rare two forms, are bullous impetigo, which is Staph aureus, and they tend to be large blisters. Usually you see them in kids, and will often go systemic, so fever, diarrhea, that kind of thing. The eczema type impetigo is related to people with chronic skin conditions, poor circulation, often older people with it. Eczema means fish-like, so it's kind of fishy skin. Uh, they can get really pus-filled blisters, usually where there's bad circulation, so ankles, feet, that kind of thing. It can go deep and into lymph nodes, and be, generally can cause some permanent damage. But it is this, it's this one that you normally will see in kids. So they treat it with antibiotic creams because it is a bacterial infection. Most of the time they don't treat it with oral antibiotics. It's just usually you catch it early enough, you isolate, you use drying agents to dry out the crust. I've heard of people using vinegar to soften the crust and try and remove it, because that crust harbors the bacteria. Uh, if it starts to go systemic, if it gets widespread, then it can have serious complications, especially and scarring and that kind of things. But it can lead to a blood poisoning and septicemia. So you want to treat that aggressively. Best way is to not get it. So chapped skin around the mouth or around the nose is probably a good idea. Covering any sort of lesions. You don't want people touching it. You got to be very careful that you don't inoculate bedding and then spread it that way, like if you pillowcases and things like that. So yeah, you got to be careful with clients with it, because they can inoculate your linens. If it's gone systemic, then it's contraindicated.